Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and today we will be wrapping up our series on prostate cancer for now with a discussion on metastatic prostate cancer. I wanted to have a separate talk specifically on the management of metastatic prostate cancer, just because I think there's a lot of unique data in the metastatic setting, specifically for this disease site. So with prostate cancer, as we will talk about, there is evidence for a benefit to treating the prostate itself, so the primary tumor, in certain patients with metastatic disease. There's evidence for a benefit to treating oligometastatic disease, so SBRT to oligometastases, which is not necessarily unique to prostate cancer, but there have been multiple studies specifically in the prostate cancer space that have shown a benefit. And then finally, there's also radiopharmaceutical therapy using isotopes such as radium-223 and lutetium-177, which have shown a benefit in prostate cancer as well. And so what I'd like to do is kind of start by talking about how we classify metastatic prostate cancer, and why we classify it the way that we do, and then getting into some of the data for some of those treatment paradigms that I mentioned. If you watched our talk on systemic therapy for prostate cancer, we had a discussion about the difference between castrate-sensitive and castrate-resistant prostate cancer. Now, the term castrate is used because we are talking about suppression of testosterone, essentially. But in the modern era, we're not actually performing castration. It's kind of a chemical castration because we're giving androgen deprivation therapy. So what is the difference between castrate-sensitive versus castrate-resistant? So castrate-sensitive prostate cancer is defined as prostate cancer that is responding to androgen deprivation therapy. So in the metastatic setting, we often will monitor patients' PSA and their testosterone levels as well. If prostate cancer is castrate-sensitive, that means that testosterone is adequately suppressed and the PSA level is adequately either declining or undetectable. With castrate-resistant prostate cancer, we're talking about a state of clinical or biochemical progression in an environment where we have adequately suppressed serum testosterone. So a castrate environment is said to be a low testosterone environment. So the serum testosterone concentration is less than 50 nanograms per deciliter. And despite an adequately suppressed testosterone concentration, patients that continue to have clinical or biochemical progression with a rising PSA are then said to have castrate-resistant prostate cancer. So we always need to measure the patient's testosterone levels, and then we need to monitor their PSA and also look at their imaging to see if they are having any signs of progression. And that's sort of the difference between castrate-sensitive versus castrate-resistant. All prostate cancers are thought to start out as a castrate-sensitive state, but then as they kind of continue to divide, they can sort of become castrate-resistant over time. And sometimes prostate cancer can even kind of de-differentiate, and that can make it castrate-resistant. And then finally, sometimes we can actually have neuroendocrine histology, which we have to kind of think about as a different disease process compared to prostate adenocarcinoma. In this talk, we're really going to just focus on prostate adenocarcinoma, keeping in mind that that is divided into castrate-sensitive versus castrate-resistant. And when we think about metastatic castrate-sensitive prostate cancer, there's an additional kind of classification that we have to think about, and that relates to the volume of disease. So with castrate-sensitive prostate cancer, we can divide it into low volume versus high volume disease. Now, different trials have used various criteria to differentiate high volume versus low volume disease, but I think the best data that we have and sort of the most consistently used definition comes from the CHARTED trial, which was an important trial for medical oncology, and it established the addition of docetaxel to androgen deprivation therapy and showed that addition of docetaxel provides a very significant overall survival benefit for patients that have high volume disease. So how did they differentiate low versus high volume disease in the charted trial? The charted definitions for low volume disease included patients that had 3 or fewer bone metastases in total, or bone metastases that only involved the vertebral bodies or pelvis. So only axial bone metastases, no appendicular bone metastases. And they were allowed to have any number of pelvic nodal metastases. So I do want to kind of classify or kind of specify the pelvic nodal metastases were not included in the charted definition, but this was then later added based on a revision of STAMPEDE trials that we will talk about. So the kind of commonly used definition of low volume disease is 3 or fewer bone metastases in total, or bone metastases only involving the axial skeleton. And now, based on STAMPEDE, we also include patients that had any number of pelvic nodal metastases. High volume disease, on the other hand, was any presence of visceral metastases or 4 or more bone lesions with at least one of those outside of the axial skeleton, so at least one involving the appendicular skeleton. That was considered high volume disease. Now, like everything in oncology, these definitions are a little bit convoluted. So an easy way to remember low volume is 3 or fewer bone metastases, and high volume is 4 or more bone metastases or presence of visceral metastases. But you do want to keep in mind that they did sort of have that qualifier for high volume, that if you're going to have 4 or more bone lesions and call it high volume, at least one of those needs to be outside of the vertebral bodies or pelvis. So these are sort of well-established definitions of low volume versus high volume disease. The reason these kind of classifications are important, the castrate-sensitive versus castrate-resistant, and then within castrate-sensitive, low volume versus high volume, the reason that these classifiers are so important is because they help us to group patients into various prognostic groups, and it really guides our treatment for these patients. So not all patients with metastatic prostate cancer are managed the same. So on this slide, I'd just like to go over kind of a very brief summary and an overview of how we manage these patients, and then we'll spend the rest of the talk sort of diving into the evidence behind these paradigms. So metastatic castrate-sensitive prostate cancer, as we said, is divided into low volume versus high volume disease based on those charted definitions that we just went over. And with low volume disease, the standard is really to think about doublet therapy. So androgen deprivation therapy, and when we say androgen deprivation therapy, we're thinking about something like a GnRH agonist, such as leuprolide. Certain patients, we can also use an GnRH antagonist, such as relugolix. But when we say ADT, think about something like leuprolide. And then we're adding an additional kind of androgen suppression, such as abiraterone, apalutamide, or enzalutamide. And if you want more details about what these drugs are, I would recommend checking out the talk on systemic therapy for prostate cancer, because we do sort of get into the mechanisms of these drugs. But doublet therapy, so ADT plus some other androgen suppressing agent. And then, as we will talk about, there's actually an overall survival benefit based on the data that we have for prostate-directed radiotherapy for these low volume patients. And then there's also a progression-free survival benefit for metastasis-directed therapy using either surgery or SBRT for patients with up to 5 metastases. For high volume disease, for patients with metastatic castrate-sensitive prostate cancer, like we said earlier, based on the charted trial, we add docetaxel to these patients. So they benefit from triplet therapy, which is the ADT plus the additional suppression using something like abiraterone or darolutamide. And then these patients also benefit from adding that chemotherapy of docetaxel. And then we have some data in an abstract that was presented at ASCO recently, but there's some evidence that prostate-directed radiotherapy, even in patients with high-volume disease, might provide some benefit. It's probably not an overall survival benefit, but it can at least kind of provide some local control, and prolong their time to adverse genitourinary events. So that's sort of maybe an area of controversy, and maybe an area that is still developing based on that the manuscript hasn't been published yet, but that's something to keep in mind. So we typically think about an overall survival benefit to prostate-directed radiotherapy, and a benefit to progression-free survival with SBRT to up to 5 metastases, and that we think about for patients with low-volume castrate-sensitive disease. For patients with high-volume disease, obviously radiation is not out of the question for these patients, but we just have to realize that the benefits that we are providing them may be a little bit different. It might have to do more with local control and kind of symptom control, as opposed to a progression-free survival or an overall survival benefit. And we'll talk more about that data very shortly here and kind of analyze it a little bit further. So that's castrate-sensitive prostate cancer. Moving on then to metastatic castrate-resistant prostate cancer. So we have many options for treating adenocarcinoma that's castrate-resistant, depending on the extent of prior therapy. And there's, in the NCCN guidelines, there's many different systemic therapy options. A lot of times these patients can still benefit from ADT, and we think about docetaxel as well. We can look for certain markers. So for example, if they are BRCA mutant, then we can add olaparib, which is a PARP inhibitor. For patients that are microsatellite unstable, and this is true not just for prostate cancer, but for many other disease sites as well. But if they have microsatellite instability, they can benefit from immune checkpoint inhibitors, such as pembrolizumab, which is a PD-1 inhibitor. And then if patients are kind of progressing on docetaxel, we can think about other agents like cabazitaxel, or sometimes they can get a re-challenge with docetaxel. So there's many systemic therapy options, even for patients with castrate-resistant prostate adenocarcinoma. And the radiation oncology team can get involved in a very important way by treating with radiopharmaceuticals. And so we will talk about the data for this as well. But there are 2 main radiopharmaceuticals that have emerged that are very, very beneficial for patients with prostate adenocarcinoma at this time. And radium-223, the brand name for this is Xofigo, is typically used for patients that have bone-only metastases. And then lutetium-177 with PSMA-617, the brand name for this is Pluvicto. This is a drug that is used for patients that have bone and soft tissue metastases. So we'll talk about the data for that. And then finally, we did briefly mention that if patients have neuroendocrine differentiation, at that point we would think about using chemotherapy drugs that we use for patients with neuroendocrine differentiation, right? So it's something like a platinum-based treatment with etoposide, like cisplatin etoposide or carboplatin etoposide, something like that. And so this is kind of just a big overview of how we think about managing metastatic prostate cancer when it comes to systemic therapy. And then I did try to kind of pepper in and talk about where radiation oncologists might be useful. So now let's kind of take a step back and get into some of the data for these paradigms. Let's start by talking about evidence for radiating the prostate with patients with castrate-sensitive prostate cancer that have a low metastatic burden. Remember, we said that for patients with low-volume disease and castrate-sensitive prostate cancer, radiation to the prostate itself can actually improve overall survival in these patients. And this is something I think that's very unique to prostate cancer. Obviously, when patients have metastatic disease, we think about treating anything that's causing symptoms such as pain or bleeding or any kind of local problems. We can always do palliative radiation. But I think it's pretty unique to have evidence for improving overall survival with radiation to the primary tumor, even in the metastatic setting. So let's talk about where that comes from. So the STAMPEDE data was the first data that we had to support radiating the primary tumor for patients with metastatic disease that had prostate cancer. So this trial was run in the UK, and I always got confused when I heard STAMPEDE because people would use STAMPEDE to justify doing a lot of different things for a lot of different types of prostate cancer, not just metastatic prostate cancer. And I really didn't understand, why STAMPEDE did so many different things. But this was actually a multi-arm, multi-stage study that compared the effects of various agents, and one of the questions that they also looked at was radiating the primary tumor. So STAMPEDE had multiple publications, not just this one, and I don't know of a good way of kind of like numbering it or anything. You just have to kind of know which specific study when it comes to the STAMPEDE data you're talking about. So there was one study within kind of all of the studies that were conducted as part of the STAMPEDE umbrella that investigated the question of radiating the primary tumor for patients with M1 disease. So they took about 2,000 men in a phase 3 randomized controlled trial who had de novo metastatic prostate cancer. And when someone is being diagnosed with a de novo metastatic prostate cancer, it's said to be castrate sensitive from the get-go because they haven't yet been exposed to androgen suppression. So they stratified patients with de novo metastatic prostate cancer based on the definitions that were used in the charted trial that we talked about. So high metastatic burden versus low metastatic burden. And these patients were staged using CT or MRI-based imaging. So importantly, in the modern era, we now use PSMA PET CTs a lot. Pretty much everyone with either unfavorable intermediate risk or higher disease and metastatic disease is going to get a PSMA PET scan. But we do have to take that with a little grain of salt and keep in mind that STAMPEDE did not stage these patients with a PSMA PET scan. So they divided patients into strata. So they stratified them based on high or low metastatic burden as per the charted definitions. And then they were randomized to either the standard of care, which was lifelong androgen deprivation therapy. And then once docetaxel received FDA approval, about 18% of patients on this study received docetaxel once that became approved. And then the experimental arm involved the kind of standard systemic therapy plus external beam radiation to the prostate. And the radiation regimens that they used were either 55 gray and 20 fractions delivered daily over 4 weeks, or 36 gray and 6 fractions delivered once a week over 6 weeks total. And it was about a 50-50 split in terms of who got which regimen. And then, obviously they received that systemic therapy that was standard. So the patients with de novo metastatic prostate cancer were stratified based on high or low metastatic burden, and then randomized to either just systemic therapy or systemic therapy plus radiation to the prostate. The results showed that at 5 years, there was a significantly improved overall survival only for patients with low metastatic burden. So for patients with low metastatic burden, the 5-year overall survival was 53% without radiation, improved up to 65% with radiation. So a 12% 5-year overall survival benefit. For patients with high metastatic disease, the 5-year overall survival was not significantly different. It was 35% without radiation, 30% with radiation. The failure-free survival did improve across all patients, but importantly, that overall survival benefit was really just seen in patients with low volume disease. There was no significant difference in the quality of life between the groups. So it was just around a 73% versus 72% average global quality of life score at 2 years. No significant difference in grade 3 or worse overall toxicity between the arms. And the toxicity really was kind of even between the two different arms. These are the Kaplan-Meier curves for overall survival from these STAMPEDE patients, just to sort of drive home the point. So when they looked at all patients, there did not seem to be a benefit to radiating the primary tumor, but when they separated them out based on those stratifications, so low versus high metastatic burden. In the low metastatic burden group, the overall survival did significantly improve. So it went from 61 months median overall survival up to 85 months with radiation to the primary tumor. There was no such benefit seen for patients with high metastatic burden. So STAMPEDE, in conclusion, improved overall survival with prostate radiotherapy in patients with metastatic de novo prostate cancer who had low burden metastatic disease. The dose regimens that they used varied based on institution. So they used both 55 gray and 20 fractions daily or 36 gray and 6 fractions weekly. I have heard of, people doing many different things in actual practice, and I think this just varies based on institution. In my practice, what I have seen is 55 gray and 20 fractions most commonly. I think some people might extrapolate the 36 gray and 6 fractions weekly and think about offering SBRT. And this is actually going to be allowed in the next iteration of STAMPEDE. But I think institutional practices just vary. But they didn't use kind of like that full definitive dose of 60 gray and 20 fractions. They used 55 gray and 20 fractions. And I think that's important because with that lower dose, they showed no significant worsening of toxicity. And keep in mind, we're treating patients with metastatic disease, so we really don't want to do anything to cause worse toxicity for these folks. There's a few other trials that are important to be aware of that ask similar questions. So the HORAD trial looked at patients that were treated with androgen deprivation therapy with or without radiotherapy, and they used different doses. So they used either 70 gray and 35 conventionally fractionated or 57.76 in 19 fractions. And the HORAD trial actually showed no significant overall survival or failure-free survival benefit. But they did kind of include patients with PSA greater than 20 and bone-only metastases. And the definition of low metastatic burden in the HORAD trial was a little bit different. So they included patients with less than 5 bone lesions and a PSA less than or equal to 142. So they might have had kind of higher risk or more advanced patients within their low metastatic burden group, and they did not end up showing any overall survival benefit. The STAMPEDE and HORAD trials were then kind of prospectively looked at in a meta-analysis, so a prospective meta-analysis of these two separate studies, STAMPEDE and HORAD, in what is known as the stopgap meta-analysis. And in this stopgap meta-analysis, when all of these patients were looked at together, prostate-directed radiotherapy did actually show a 7% improvement in overall survival at 3 years in patients with less than 5 bone lesions. So the 3-year overall survival was 70% without radiation and improved to 77% with the addition of radiation, and that was significant. So once again, stopgap kind of supports the conclusion from STAMPEDE that in unselected patients with de novo metastatic disease, there does not really seem to be an overall survival benefit, but there still is kind of a 10% failure-free survival and biochemical progression-free survival benefit. But then once we do select based on metastatic burden for patients with low volume disease, it turns out that there is some degree of overall survival benefit for patients with low volume disease. And keep in mind that the definitions of low volume disease were different between STAMPEDE and HORAD, and then that stopgap meta-analysis used the definition of less than 5 bone metastases. Also, in all of these studies, once again, I want to reiterate, these patients were staged by kind of conventional imaging, so using CT or MRI. They did not get a PSMA PET scan. In the era of PSMA PET scans, we are likely to upstage some of these patients because, PSMA PET scan might show certain things that we don't see just on CT or MRI alone. So again, we have to take the PSMA scans with a grain of salt when we're thinking about how to manage patients in the modern era. I just briefly want to mention the Piece 1 trial, which was presented in abstract form at ASCO recently. And the only reason I want to mention this is because it sort of adds another consideration for treating the prostate itself for patients with metastatic disease. So we talked about STAMPEDE and stopgap, which showed that for patients with low volume de novo metastatic prostate cancer, we actually have an overall survival benefit with primary radiotherapy to the prostate. Piece 1 was interesting because it took patients with de novo metastatic castrate-sensitive prostate cancer, and it had a 2x2 factorial design. So there were 4 different arms ultimately. The systemic therapy question was, do we do standard of care, which is androgen deprivation therapy with or without docetaxel, or do we do that standard of care plus abiraterone and prednisone? And then the radiation question was, do we do systemic therapy alone, or do we do systemic therapy plus radiation to the prostate, 74 gray and 37 fractions? And so that 2x2 factorial design led to 4 different arms, and they found that the addition of abiraterone to the standard of care did improve radiographic progression-free survival as well as overall survival. And they found that in the low volume population, the addition of prostate radiotherapy improved radiographic progression-free survival from 4.4 years without prostate radiation up to 7.5 years with radiation, but they did not see a significant overall survival benefit. And then in the overall population, they actually found that there was an improved time to serious genitourinary events, as well as castration-resistance free survival. So again, this study has not yet been published in manuscript form, and so we really need to wait for that to kind of draw more conclusions. I think it was a little bit murky because they defined time to serious GU events. One of the definitions was receiving radiation to the prostate. So I think that makes it a little bit hard to kind of interpret. But some folks, I just wanted to mention this, are using the Piece 1 data to kind of provide a rationale for treating metastatic prostate cancer with prostate-directed radiotherapy because it does, it can improve that time to GU event and castration resistance-free survival. So, in this setting, when we're treating the prostate for patients with kind of higher volume metastatic burden, we have to keep in mind that we're not necessarily providing an overall survival benefit as we saw in those previous trials, but we might be providing some sort of local benefit at least. So it's just important to be honest about what the endpoint is, what the goal is with the radiation if we do treat the prostate. So that wraps up the studies that I wanted to talk about regarding radiation to the primary tumor in the setting of metastatic prostate cancer. So what we saw is that it does provide a benefit, and we have different options for dosing for this situation. So 55 gray in 20 fractions daily over 4 weeks was done in Stampede. They also did 36 gray in 6 fractions weekly, and some might extrapolate this and consider doing SBRT. 55 and 20 is what I have most commonly seen used in this setting. Now, we have to be honest with ourselves and with our patients, obviously, about the benefit of this therapy. So what is that benefit? As we saw in the Stampede and then the StopCap meta-analysis, for patients that have low metastatic burden, and per the charted trial, low metastatic burden is defined as 3 or fewer bone metastases, or bone metastases that are only involving the axial skeleton. So really the vertebrae and the pelvis. And so the overall survival benefit for these patients was around 12% in Stampede at 5 years, around 7% in StopCap at 3 years. And that's really the benefit that we're providing to these patients with low volume metastatic disease. There's also a progression-free survival benefit for low metastatic burden that's supported by Piece 1. And, obviously Piece 1, we're still waiting for the manuscript, but some people will use this to justify treating even patients with higher volume metastatic disease with the idea that we're not necessarily providing an overall survival benefit or a progression-free survival benefit, but at least a local control benefit in terms of time to serious genitourinary events and castration resistance-free survival. So again, many different indications to treat the prostate itself. I think the strongest indications are for patients with low volume disease because we do have that overall survival benefit. And the last thing I want to just re-emphasize is that in the era of PSMA PET scans, we do really need to exercise caution and be very careful when we're interpreting those PSMA PET scans. Moving on then, let's get into some evidence for SBRT to sites of metastasis in patients with oligometastatic prostate cancer. I think this area is no longer unique to prostate cancer because we are providing SBRT to metastatic disease in many different diseases and finding that it does improve progression-free survival. There's a lot of phase 2 data for this, and phase 3 trials are ongoing, and it looks very promising, especially for prostate cancer. So a very famous trial that looked at SBRT for oligometastatic cancer across many different disease sites was the SABR-COMET study, and it was a phase 2 study, and it actually showed an overall survival benefit for patients that were treated with SBRT for their oligometastatic sites. In this study, however, only 16% of patients had prostate cancer. In SABR-COMET, there were a lot of patients with lung cancer and other primaries as well. So what I want to share here is sort of studies that were specific to just prostate cancer patients. So the first of these studies is the STOMP trial. This was a phase 2 randomized controlled trial. I believe this is a Belgian study. And they took 60 patients with recurrent prostate cancer with 3 or fewer oligometastatic lesions on a choline PET scan, and they had to have a testosterone greater than 50 when they were diagnosed with that recurrence. And they were randomized to either surveillance or metastatic-directed therapy with either surgery or SBRT to all sites of metastasis. And the androgen deprivation therapy-free survival improved when they received metastasis-directed therapy. So the ADT-free survival was 13 months with surveillance compared to 21 months when they added metastasis-directed therapy. And the median time to progression or PSA progression was 6 months with surveillance versus 10 months with metastasis-directed therapy. And they found no significant differences in their health-related quality of life. So STOMP provides some phase 2 evidence for oligometastatic-directed therapy, so either SBRT or surgery, and found that it improves ADT-free survival and time to PSA progression. Oriole was a very similar study, phase 2 randomized controlled trial, similar sample size, 54 men, with recurrent metastatic castrate-sensitive prostate cancer and 1 to 3 oligometastatic lesions seen on either CT, MRI, or bone scan. And these patients had to have prior treatment to the primary tumor and no androgen deprivation therapy in the last 6 months. And these patients were then randomized very similarly to STOMP to either observation or SBRT to the metastatic lesions. And what they found is that there were lower rates of progression with metastasis-directed SBRT. So the 6 months rates of progression were 19% with SBRT versus 61% with observation, and that was statistically significant. SBRT did improve the median progression-free survival, and the other kind of caveat is that they did have higher rates of Gleason score 9 and 10 disease in the arm that was observed. They did not see any grade 3 or worse toxicities. So STOMP and Oriole now, or Oriole adds another kind of layer to the evidence that there seems to be reduced rates of progression with metastasis-directed SBRT. And these are both phase 2 trials. There was also a pooled analysis of the Oriole and STAMP studies, and this showed a significant improvement in the median progression-free survival with metastasis-directed therapy. So I think these are good numbers to remember. The median progression-free survival was 6 months with observation versus 12 months with metastasis-directed therapy in the STOMP and Oriole pooled analyses. So remember, both STOMP and Oriole compared observation versus metastasis-directed therapy for patients with 3 or fewer bone metastases. So that kind of meets that low volume definition as well that we talked about. And there was a significant improvement to progression-free survival. And then finally, the last phase 2 trial I'll mention here is the Extend trial that actually looked at patients with 5 or fewer metastases, so slightly higher number of metastases in oligometastatic castrate-sensitive prostate cancer. And these patients received androgen deprivation therapy for at least 2 months. So they were randomized to either continued androgen deprivation therapy alone or androgen deprivation therapy plus SBRT to the metastatic lesions. And Extend showed a significantly improved progression-free survival with the addition of SBRT. The median progression-free survival was 16 months in the group that received ADT alone, and it was not reached in patients that received ADT plus SBRT. There was also significant improvement in the time from testosterone recovery to progression, so what we call the eugonadal progression-free survival. And what they found is that they did a flow cytometry and sort of T cell receptor sequencing analysis, and they found that there were increased markers of T cell activation, proliferation, and clonal expansion in the arm that received SBRT, suggesting that SBRT might actually result in immune stimulation and help contribute to systemic disease control. So once again, Extend is another trial looking at ADT versus ADT plus SBRT for patients with up to 5 metastases, and it demonstrates that SBRT may even allow for sort of intermittent androgen deprivation for patients with oligometastatic disease. And androgen deprivation therapy is not fun for patients to go through. It has a lot of toxicities and adds morbidity for patients. And so anything we can do to kind of reduce the duration that they need to be on androgen deprivation, I think, is really important. These phase 2 trials that we talked about, STOMP, ORIOLE, and Extend, they do provide, I think, robust evidence for us to be treating patients with oligometastatic disease with metastasis-directed therapy using SBRT. And there are kind of more ongoing trials as well. So there's a CCTG PR20 trial, which is a phase 3 trial that's ongoing, comparing local ablative therapy versus standard of care for patients with oligometastatic castrate-sensitive prostate cancer that have less than or equal to 5 metastases, so similar to Extend, but it's a phase 3 trial. There's a trial called the Promethean study, or NRG-GU0011, which is a phase 2 trial for early recurrent oligometastatic prostate cancer that's detected by PET, treated with SBRT plus relugolix versus a placebo. And then there's also PCS9, which is a phase 2/3 adaptive trial for patients with metastatic castrate-resistant prostate cancer with oligometastases. So far we've really been talking about castrate-sensitive. The PCS9 is looking at castrate-resistant. So these are just some of the ongoing trials. But there's a lot of work being done in this space, and it'll be exciting to see the results of these trials. I think the biggest takeaways from what we've talked about so far is that we have a lot of phase 2 data supporting a benefit to metastasis-directed therapy for up to 5 oligometastatic lesions. And we saw, based on the STOMP and ORIOLE meta-analysis, that there was a progression-free survival benefit that doubled, right? 6 months with observation versus 12 months versus with metastasis-directed therapy. And then based on Extend, we saw that there was a significant ADT-free survival as well, so time that these patients did not have to be on androgen deprivation therapy. So we've talked about the evidence for prostate-directed radiotherapy in patients with metastatic disease. We've talked about the evidence for SBRT to oligometastatic disease in prostate cancer. And we're going to end our talk with a discussion of a couple of trials showing the role of radiopharmaceutical therapy for patients with metastatic castrate-resistant prostate cancer. And it turns out that these radiopharmaceuticals that we mentioned, so Xofigo, which is radium-223, and Pluvicto, which is lutetium-177 attached to PSMA-617, these actually improve overall survival for our patients with metastatic castrate-resistant prostate cancer. So radium-223, or Xofigo, was first used as a radiopharmaceutical to treat prostate cancer based on the ALSYMCA trial, which was published more than 10 years ago now. So this was a trial of around 900 patients with metastatic castrate-resistant prostate cancer who had 2 or more bone-only metastases, and they were randomized in a 2-to-1 fashion to either 6 injections of Xofigo administered every 4 weeks or standard of care therapy. And the Xofigo injections given monthly for 6 months turned out that actually Xofigo improved overall survival, time to first skeletal event, as well as time to increase in alk-phos in these patients. So the median overall survival improved by around 3 months. So it went from 11 months with standard of care up to 15 months with the addition of Xofigo. The median time to skeletal event improved by around 6 months, so from around 10 months up to 16 months, and the median time to rise in alk-phos increased by about double, from 3.8 to 7.4 months. There was no significant increase in toxicity with radium-223, and patients actually reported an improved quality of life during the period of drug administration. And the study ended up getting terminated early due to efficacy at interim analysis. So Alsimka showed that radium-223 injections, Xofigo, which are given once a month every month for 6 months in a row, Xofigo improved overall survival in patients with metastatic castrate-resistant prostate cancer with bone-only metastases. Now, keep in mind that in order to be eligible for Xofigo, patients did have to have decent labs. So they had to have a hemoglobin greater than 10, platelets greater than 100, and an ANC greater than 1500. These labs are important to know because when we're administering Xofigo, we actually have to check them monthly prior to the injection and make sure that labs are adequate, just because radium-223 can sort of suppress some of these things, like it can cause thrombocytopenia and things like that. So we do have to keep an eye on patients' labs. So this was kind of the evidence, and radium-223 improved overall survival in these patients with bone-only metastases. The VISION trial was very similar to the Alsimka trial, but this time testing the utility of Pluvicto, which, as we said, is lutetium-177 attached to PSMA-617. So this trial included patients with at least one metastasis that was PSMA positive on a PSMA PET scan, and these patients were randomized 2-to-1 to Pluvicto, given every 6 weeks for 4 to 6 cycles plus the standard of care versus standard of care alone. And what they found is that Pluvicto injections improved overall survival and progression-free survival. So the median overall survival, very similar to what we saw with Alsimka, went from 11 months without the radiopharmaceutical up to 15 months with Pluvicto. And the median image-based progression-free survival improved significantly from 3.5 months up to almost 9 months. They did see a higher incidence of grade 3 or worse toxicity with Pluvicto, but the quality of life was not adversely affected. Pluvicto, similar to Xofigo, can cause some myelosuppression as well, so we do have to watch out for patients' labs. So the VISION trial, in conclusion, showed that Pluvicto improves overall survival and progression-free survival in patients with PSMA-positive metastasis. And on this trial, patients were allowed to have bone mets or visceral metastases, whereas remember, with Alsimka, Xofigo was only effective for patients with bone metastases. When I first heard about Xofigo and Pluvicto, I wondered, why is that? Why can we use Pluvicto for any mets, bone or visceral, but Xofigo we only use for bone-only metastases? And it really has to do with the mechanism. So Xofigo, or radium-223, emits alpha particles, and it has a very short range. And the mechanism of action for radium-223 is it's really a calcium mimetic, and so it gets taken up by bone metastases, which are typically osteoblastic for prostate cancer and undergoing a high turnover of calcium. And so the radium-223 acts as a calcium mimetic and gets taken up by that bone that's turning over. And so that's why with Xofigo, we're really only treating bone-only metastases. Lutetium-177 is attached to PSMA-617, and the lutetium emits beta particles and gamma rays and tends to have kind of a slightly longer range. And it's taken up by prostate cancer cells that express PSMA. And so that mechanism is different. So any met can express PSMA, right? Doesn't have to be a bone-only met. It can also be a visceral met. And so that's why Pluvicto can work with bone and or visceral metastases. Both of these agents, both Xofigo as well as Pluvicto, can cause myelosuppression, especially thrombocytopenia. So we do have to check labs every time before we're giving the injection. Xofigo can also cause GI toxicity, and it can cause edema. Now, there is a retrospective trial out of Germany that demonstrates that it is safe to administer Pluvicto even after patients have gotten 6 cycles of Xofigo. And it's even safe within 6 months of the Xofigo. And there's actually an ongoing trial called the Alphabet study, which makes sense because alpha and beta emitters, Xofigo and Pluvicto respectively. But this alpha-beta trial is investigating the delivery of both of these agents together. So lots of exciting ongoing areas of investigation within radiopharmaceuticals as well. This brings us to an end of our discussion on management of metastatic prostate cancer. And just for some major takeaways at the end of everything we've talked about, we started out by talking about how we classify metastatic prostate cancer. We talked about castrate-sensitive versus castrate-resistant, and within castrate-sensitive, we talked about low-volume versus high-volume disease based on the charted trial, so the charted definition. And then we started talking about kind of unique considerations for management of metastatic prostate cancer. The first consideration we talked about was prostate-directed radiotherapy for metastatic castrate-sensitive prostate cancer. So prostate-directed radiotherapy, we showed, improves overall survival in patients with low-volume disease, and that's based on the STAMPEDE trial as well as the STOP-CAP meta-analysis. And then, we also talked about piece 1 data, which has so far only been presented as an abstract, but suggests that maybe even in high volume disease, there might be some kind of local control and toxicity benefit. We then moved on to talk about metastasis-directed radiotherapy, so SBRT to areas of oligometastases in particular. And there's a lot of phase 2 evidence for improved progression-free survival when we provide SBRT for patients with up to 5 metastases. So we talked about the STOMP and ORIOLE trials, which looked at patients with up to 3 oligometastases. And then we talked about the EXTEND trial, which included patients with up to 5 oligometastases. And then there's an ongoing PCS9 trial that's looking at SBRT from patients with castrate-resistant prostate cancer. And then finally, we ended our discussion with a talk on radiopharmaceuticals for metastatic castrate-resistant prostate cancer. And we talked about the overall survival benefit provided by radium-223 or Xofigo for bone-only metastases, and then lutetium-177 or Pluvicto for PSMA-positive bone and or visceral metastases. So prostate-directed radiotherapy, SBRT for areas of oligometastases, and then radiopharmaceuticals for castrate-resistant prostate cancer. Thank you so much for all your time and attention. I really hope that this prostate cancer series has been helpful in kind of breaking down and dissecting what I think is a very complex and overwhelming disease site. I certainly had a lot of trouble kind of making sense of a lot of these trials as I was reading through them early in my residency. So hopefully this provided at least some degree of context, made things make sense a little bit. And, I wish you happy studying and there's a lot more trials that we probably could have talked about that we didn't mention here for the sake of time. But hopefully this provides a nice kind of skeleton on which you can build your knowledge of prostate cancer. Thank you so much again for everything.